Welcome to the deep dive. Okay, let's set the scene. Imagine you're a nurse, right? And a patient comes in presenting with, well, anything from a pesky nosebleed to something really life-altering, like a cancer affecting how they breathe or speak. It's quite a range. And that's the intricate world we're exploring today. We're taking a deep dive into Chapter 29 of Lewis's Medical Surgical Nursing. It's really a cornerstone for understanding these upper respiratory issues and head and neck cancers. Our mission here, basically to give you a shortcut to being genuinely well informed. We want to pull out the most important nuggets for your nursing practice and definitely help prep you for those critical NCLEX style questions.
Absolutely. And what's truly fascinating, I think, is how seemingly minor issues, in the upper respiratory system can actually have these profound systemic impacts. It's really not just about a runny nose. It's about how these conditions affect a patient's breathing, their nutrition, sleep, body image, even mental health. This chapter really drives home the need for that holistic care, especially when we start talking about complex conditions like head and neck cancers. We'll try to connect those dots between symptoms, diagnosis, and like the crucial why it matters for every single nursing intervention you'll do.
That really frames the challenge for us nurses, doesn't it? That holistic view. So, okay, let's zoom in a bit. We'll start with the more common things, nasal and sinus problems, figuring out when routine stuff becomes, well, critical. Then we'll move down to challenges in the throat and voice box, focusing on protecting those vital airways and communication. And finally, yeah, a really comprehensive look at head and neck cancers. Everything from early detection to, really intricate post-surgical journey and that patient-centered care focus. We'll break down the pathophysiology, what you need to look for, how it's diagnosed, and crucially, the essential nursing actions you've really got to master. All right, first step, let's talk about the very foundation of our breathing, the nose and sinuses. Expert, what's a common, maybe often overlooked issue here that can really impact a patient's quality of life?
Yeah, good place to start. Let's consider a deviated septum. So this is when that wall inside your nose, the septum cartilage and bone, is significantly shifted over to one side. Now, while like maybe up to 80% of adults have slight deviations, a really severe one can cause problems. Think chronic nasal congestion, frequent sinus infections, even nosebleeds and facial pain sometimes just because the airflow is obstructed. Diagnosis is usually pretty straightforward, just a quick look with the nasal speculum. For minor symptoms, sure, saline rinses, maybe some decongestants can help manage the congestion. But for those really problematic deviations, a septoplasty, which is basically surgical reconstruction, that's the definitive fix.
Okay, so from those slight shifts to maybe more sudden trauma, nasal fractures, you mentioned they're actually the most common
Right.
facial fracture, often from falls or sports injuries, right? But beyond the obvious swelling and maybe bruising, what's a really critical sign that we as nurses absolutely need to be looking for?
That's a critical connection to make, especially after blunt trauma.
Yeah, beyond the local pain, the swelling, maybe even crepitus, that kind of grating sound or feeling, we have to be super vigilant for something called raccoon eyes.
Yeah.
It's bruising around both eyes, and it strongly suggests a basilar skull fracture, a break at the base of the skull, which means there's a high risk of CSF leakage.
CSF, cerebrospinal fluid, wow.
Exactly. The fluid surrounding the brain and spinal cord, it could potentially be leaking right into the nasal passages. So if you see clear or maybe pink-tinged drainage that just keeps going after any initial bleeding stops, you absolutely must send a sample to the lab. Got to check for CSF. Our immediate nursing priorities. Number one, maintain a patent airway, keep the patient sitting upright. Then reduce the edema and pain, usually with ice. And this is crucial. Avoid NSAIDs or aspirin for the first 48 hours. We don't want to increase any bleeding risk. Got it. No NSAIDs for 48 hours. So if surgery is needed, maybe a rhinoplasty, reconstructing the nose either cosmetically or for function after trauma. You mentioned pre-op assessment is key, especially patient expectations, and making sure they stop aspirin and NSAIDs 5 days to 2 weeks before surgery. That sounds non-negotiable for bleeding. Postoperatively, then, what are the absolute top priorities for nursing care?
Airway patency, always, always number one. So continuous respiratory assessment is vital, then pain management, of course. And just really vigilant observation of that surgical site, looking for any signs of increased edema, bleeding, or infection. Keep in mind, they might have nasal packing inside for a day or two, maybe an external splint for a week or possibly two. And for discharge teaching, you really need to emphasize things like cold compresses, keeping the head elevated, and strict activity restrictions. Absolutely no nose blowing, no swimming, no heavy lifting, no strenuous exercise for a while. That swelling can actually take months, even up to a year, to fully resolve sometimes.
Wow, okay. Months. Good to know. All right, moving on. Epistaxis. Nosebleed. We see it all the time, right? But you mentioned it can get serious quickly, maybe especially for older adults or folks on blood thinners. So what helps us differentiate between a, run-of-the-mill nosebleed and one that needs urgent medical attention?
Yeah, that's the key distinction. Anterior versus posterior bleeds. Anterior bleeds make up about 90% of cases. They're usually visible right at the front of the nose and often stop with simple first aid. And that first aid, crucial for NCLEX, by the way, is sit the patient up, lean them slightly forward with the head tilted forward, and pinch the soft lower part of the nose firmly for about 5 to 15 minutes.
Okay, sit up, lean forward, pinch. Got it.
Right. But posterior bleeds, which are more common in older adults and often harder to actually see way back there, they can lead to significant blood loss. These almost always need medical intervention. For those, they might insert specialized packing like maybe compressed sponges or even an epistaxis balloon to apply direct pressure way back in the nasal cavity. And what's absolutely critical for nurses to remember is that any patient with posterior packing needs to be admitted to a monitored unit.
Okay. A monitored unit. Why?
Because you have to closely watch their level of consciousness, heart rate, rhythm, respiratory rate, oxygen saturation. There's a real risk of breathing difficulties, airway obstruction from the packing, even aspiration. Plus, infection risk goes up with packing. And don't forget pain management. That packing can be really uncomfortable.
Makes sense. Posterior packing equals close monitoring. Okay. From acute bleeds to maybe more chronic issues, allergic rhinitis, that constant battle with allergens, it's more than just annoying sniffles, right? It can really impact someone's life. What's the basic pathophysiology and what are our best nursing strategies?
Right, it's basically an over-the-top immune response. The first time you're exposed to an allergen, your body makes IgE, that's immunoglobulin E, an antibody specific to allergies. Then when you're exposed again, this IgE triggers mast cells and basophils to release histamine and a whole cascade of other inflammatory chemicals. And that causes the classic symptoms: sneezing, watery, itchy eyes and nose, congestion. Honestly, the most effective nursing strategy is patient education, helping them identify and then avoid their specific triggers. That could mean, washing bedding in hot water if it's dust mites, using HEPA filters, maybe avoiding damp basements for mold, staying inside during high pollen counts, things like that. Table 29.1 in Lewis's has great examples.
So trigger avoidance is number one. What about medications?
Meds definitely play a big role. We use H1 antihistamines. The second generation ones, like cetirizine or loratadine, are usually preferred because they cause minimal sedation. But the older first generation ones, like diphenhydramine, they do cause drowsiness. So a key drug alert: you absolutely have to warn patients about driving or using machinery and encourage fluid intake with antihistamines.
Okay, warning about drowsiness is critical. What else?
Decongestants are also common. Oral ones like pseudoephedrine, but watch out, another D drug alert. They can cause tachycardia, palpitations, and maybe CNS issues in older adults. Use caution with heart disease, hypertension, diabetes, glaucoma. And the nasal decongestant sprays like oxymetazoline, super important. Tell patients use for no more than 5 days. Any longer, and they risk severe rebound congestion, making things way worse.
5 days max for nasal sprays. Got it.
Right. Intranasal corticosteroids like fluticasone are excellent for reducing inflammation long-term with minimal side effects. And for some people, if drugs aren't enough or triggers are unavoidable, immunotherapy allergy shots might be an option.
Okay, that covers allergies pretty well. Now, let's tackle two that often get mixed up: the common cold or acute viral rhinopharyngitis, and influenza, the flu. Expert, what's maybe the single most important differentiating factor for us nurses? And why does that difference matter so much in practice?
Okay, the single biggest differentiator, it's the onset and the severity of symptoms. A common cold usually comes on kind of gradually. You get a runny nose, maybe some sneezing, perhaps a mild sore throat, low-grade fever, if any. It's annoying, but usually mild. The flu, though, influenza, that typically hits you like a ton of bricks. Abrupt onset, high fever like 102 to 104, severe body aches, myalgia, headache, significant fatigue, often a cough and sore throat too.
Okay, abrupt onset, high fever, body aches, think flu. Gradual, milder, think cold. Why is that distinction so critical?
It's critical because the flu isn't just a bad cold. It's a serious public health issue. It can lead to significant complications, especially pneumonia, either viral or secondary bacterial, particularly in older adults, young children, or people with chronic health conditions. It can be life-threatening. And for nursing, the key insight relates to treatment. Antiviral medications for the flu, like oseltamivir, you probably know it as Tamiflu, work best when started early.
How early?
Ideally within 48 hours of symptom onset. That's a pretty narrow window.
Yeah.
So being able to quickly recognize those flu symptoms versus cold symptoms allows for prompt testing, if needed, and timely initiation of antivirals if appropriate. That rapid assessment and patient education piece is huge.
48 hours. Okay, that really highlights the need for quick recognition. And what's our absolute best defense against the flu in the first place?
Oh, hands down, annual vaccination. This is so important for NCLEX style thinking. Advocate for everyone over 6 months old to get their flu shot every year, especially high-risk groups and us healthcare workers. The vaccine helps your body build antibodies, which takes about 2 weeks. So getting vaccinated in September or October before flu season really kicks off is ideal.
Good reminder. Any specific drug alerts related to flu treatment we should know?
Yes, one for a newer antiviral, Baloxavir marboxil, brand name Xofluza, critical point. It should not be given with dairy products or calcium-fortified drinks or foods. Calcium significantly interferes with its absorption.
No dairy or calcium with Asfaluzza. Noted. Okay, moving from viruses to inflammation, sinusitis, that blockage and infection in the sinuses. What are the telltale signs and what should nurses really emphasize when teaching patients?
All right, sinusitis is basically inflammation or swelling inside the sinuses that blocks the little openings, the ostia. Mucus gets trapped, creating a perfect breeding ground for bacteria, viruses, or sometimes fungi. Acute sinusitis lasting less than 4 weeks typically presents with pretty significant pain over the affected sinus. Maybe purulent, thick, yellowish-green nasal drainage, congestion, possibly fever, feeling unwell. Chronic sinusitis, which lasts more than 12 weeks, is often a bit more subtle. The symptoms might be less specific, maybe facial or dental pain, persistent congestion, increased drainage, but rarely a high fever. Sometimes it can mimic allergies.
Interesting. And you mentioned a connection to asthma.
Yeah, it's a strong link. Something like up to 50% of patients who have moderate to severe asthma also have chronic sinusitis. And interestingly, treating the sinusitis effectively can actually help improve their asthma control. So always keep that connection in mind.
Good clinical pearl. What about patient teaching for sinusitis?
Key points for teaching include encouraging rest, plenty of fluids for hydration, using steam inhalation like hot showers, or applying warm, damp towels to the face for pain relief. Elevating the head of the bed can help with drainage. And definitely emphasize avoiding smoking as it irritates everything. For acute cases, decongestants are often used oral or topical nasal sprays. But again, that crucial warning, topical decongestants no more than 5 days to prevent that rebound congestion. Antibiotics might be needed if symptoms worsen or persist beyond a week.
5-day rule again for those sprays. Seems important. Okay, last thing in this nasal sinus section. Obstructions like nasal polyps or foreign bodies. Any key nursing actions, especially for tricky NCLEX scenarios with foreign bodies?
Sure. Nasal polyps are those soft, benign growths, often linked to chronic inflammation like in allergies or chronic sinusitis. Corticosteroids or surgery can help, but yeah, they often recur. Now, foreign bodies in the nose, more common in kids, but can happen in adults. The absolute critical nursing action is do not irrigate the nose or try to push the object further back. The risk of aspiration is just too high.
Okay, no pushing it back. What should we do?
Encourage the patient to try gently blowing their nose while closing off the opposite nostril. Sometimes that works. Or try to induce a sneeze. If it doesn't come out easily, don't keep trying. Consult the healthcare provider for safe removal, possibly using specialized instruments.
Got it. Avoid aspiration risk at all costs. Okay, let's move down the airway now. We're talking throat, larynx areas, critical for breathing and talking. What's a common throat infection we see, and how can nurses spot the difference between that and maybe a more serious bacterial threat?
Right, we're often dealing with acute pharyngitis, basically. Inflammation of the throat walls, a sore throat. Most cases, maybe 90%, are viral. But it can be bacterial, most notably strep throat, caused by group A beta-hemolytic streptococci, GABHS. That's maybe 5–10% of adult cases. Now, telling them apart just by looking can be tough. Both can cause a red swollen throat, sometimes with exudate. But the classic presentation of bacterial pharyngitis, which is definitely something to know for NCLEX, usually involves 4 key things. A fever over 100.4 degrees FTO, 38 degrees C, enlarged anterior cervical lymph nodes, swollen glands in the neck, tonsillar or pharyngeal exudate, and this is key, the absence of a cough.
Absence of cough. Interesting. So if those criteria are met...
If 2 or 3 of those are present, a rapid antigen detection test or a throat culture is usually done to confirm strep. And if it is strep, penicillin is typically the drug of choice, and it's vital patients take the full 10-day course even if they feel better sooner. Why? to prevent serious complications like rheumatic fever.
10 full days of penicillin for strep. Crucial point. What if it's fungal, like thrush?
Fungal pharyngitis, often candida, can happen after prolonged antibiotic use with inhaled corticosteroids if the mouth isn't rinsed, or in immunosuppressed folks. You'll often see white, irregular patches. Treatment is usually nystatin antifungal suspension. Patients need to swish it around in their mouth thoroughly, hold it as long as possible, and then swallow. And yeah, always remind patients using inhaled corticosteroids to rinse their mouth with water after each use to prevent thrush.
Good tip. Now, what about potential complications of tonsillitis? I remember something about a peritonsillar abscess being serious.
Very serious, yes. A peritonsillar abscess is a complication where pus collects behind the tonsil. It's usually caused by the same strep bacteria. It causes intense pain, swelling, and can actually block the throat significantly, becoming an airway emergency. Patients often have a high fever, chills, difficulty swallowing, dysphagia, and maybe a muffled, hot potato voice. Treatment is urgent. 4V antibiotics are needed, and often the abscess needs to be drained, either by needle aspiration or incision and drainage. IND. Sometimes an emergency tonsillectomy is required.
Okay, peritonsillar abscess, potential airway emergency. Needs urgent care. Shifting focus slightly to the voice box, the larynx. What about acute laryngitis?
Acute laryngitis, inflammation of the larynx, is most often viral, maybe from a cold or flu, or sometimes just from overusing your voice, like yelling at a game. Smoke or chemical inhalation can also cause it. The hallmark symptom is hoarseness, maybe even complete voice loss. Patients might also feel a tickling or burning sensation, have a cough, or feel fullness in the throat. The most important management advice for nurses to give: voice rest. And this is key. Avoid whispering. It actually strains the vocal cords more than speaking softly.
Avoid whispering. That's counterintuitive but
It
important.
really is. Also, encourage hydration. Maybe use a humidifier. Avoid caffeine and alcohol, which can be drying. And definitely stop smoking. Usually it resolves on its own in a week or two, but if hoarseness lasts longer than 3 weeks, they need to see their provider.
Okay, this brings us to a really critical topic: acute airway obstruction. You mentioned the peritonsillar abscess, but obstruction can happen for many reasons. When does this become a true medical emergency? What are the immediate signs we need to recognize?
Acute airway obstruction is always a potential medical emergency. It can happen from aspirating food or a foreign object, severe allergic reactions causing swelling, anaphylaxis, infections like epiglottitis or abscesses, burns, trauma, or even tumors. The signs depend a bit on where the blockage is. Laryngeal obstruction might cause hoarseness or inability to speak. Tracheal obstruction might cause wheezing. But generally, the critical signs you must recognize immediately are choking, stridor, that high-pitched, harsh sound on inhalation, maybe flaring nostrils, restlessness, agitation, tachycardia, changes in level of consciousness, and cyanosis, bluish skin.
Stridor's a big one.
A huge one. Prompt assessment and treatment are absolutely non-negotiable because a partial obstruction can become complete very, very quickly. And complete obstruction, brain damage or death can occur in just 3 to 5 minutes.
3 to 5 minutes? That's terrifyingly fast. So immediate priorities.
Ensure a patent airway. That might mean the Heimlich maneuver for choking. It might mean preparing for emergency endotracheal intubation, or, in severe cases, assisting with an emergency cricothyroidotomy, an incision through the cricothyroid membrane, or a tracheostomy, a surgical opening into the trachea to bypass the obstruction. Time is absolutely critical.
Absolutely critical. Okay, that really underscores the urgency. Now, let's shift gears into what can be a very challenging area: head and neck cancer. This feels like where nursing care becomes incredibly complex, impacting not just physical health, but really a patient's whole sense of self.
You're right, it's incredibly impactful. And connecting it to the bigger picture, head and neck cancer really underscores the need for early detection, definitely comprehensive interprofessional teamwork, and very patient-centered care. The potential impact on function, breathing, eating, speaking, and quality of life is just immense. The major risk factors. Still overwhelmingly, tobacco use, smoking, chewing doesn't matter, and excessive alcohol consumption. Together, they account for something like 85% of cases.
85%, wow.
Yeah. We typically see it more in people over 50, and men are about twice as likely as women. However, there's a concerning trend.
What's that?
We're seeing an increase in these cancers in younger patients, and that's often linked to human papillomavirus, or HPV, infection, particularly certain strains associated with oropharyngeal cancers.
HPV. Okay, that's important for prevention messages too. What about prognosis?
Unfortunately, these cancers are often diagnosed at a locally advanced stage. This means they can cause significant disability. Things like voice loss, facial disfigurement, problem swallowing. which lead to major social and emotional concerns for patients.
So early detection is paramount. What are some of those subtle early signs that nurses should be educating patients about? Things people might ignore.
Exactly. Early signs can be really subtle. Things like a feeling of a lump in the throat or a persistent sore throat that just doesn't get better with usual remedies. Inside the mouth, look for leukoplakia, those white patches, or erythroplakia, reddish patches. These can be precancerous. Changes in voice quality, like persistent hoarseness lasting more than 2 weeks, is a classic warning sign, especially for laryngeal cancer. Other possible early signs include ear pain or ringing, maybe a neck lump or swelling that doesn't go away, a chronic cough, sometimes even coughing up blood, hemoptysis.
Hoarseness for more than 2 weeks. That seems like a key takeaway. What about later signs?
Later signs are usually more pronounced and indicate more advanced disease. Things like unintentional weight loss, real difficulty chewing or swallowing, maybe trouble moving the tongue or jaw, and eventually difficulty breathing or obvious airway obstruction.
So how is it diagnosed definitively?
Well, early detection relies on awareness and seeking help for those persistent symptoms. Diagnosis involves a thorough history and physical exam, really looking closely inside the mouth and throat, under the tongue, checking denture fit, palpating the neck for lymph nodes. Then, procedures like indirect laryngoscopy, using a mirror, or direct endoscopy allow visualization. Biopsies are essential to confirm cancer cells. Imaging like CT, MRI, or PT scans helps determine the extent of the tumor, and if it has spread, that's the staging process, using the TNM system, tumor nodes metastasis, which guides treatment decisions.
Okay. TNM staging guides treatment, and the treatment itself involves a whole team, right? Surgery, radiation, chemo. Let's focus on surgery for a moment, specifically a total laryngectomy. How does that profoundly change a patient's life, and what are the nursing implications?
A total laryngectomy is life-altering. It involves removing the entire larynx, the voice box. This permanently changes airflow. Think about it.
Right.
Normally, air comes in through your nose and mouth, goes down past the larynx into the trachea and lungs. Speech happens as air passes back up through the vocal cords. After a total laryngectomy, the trachea is brought forward and attached to the skin of the neck, creating a permanent opening called a stoma. Breathing now happens entirely through this stoma. The nose and mouth are essentially bypassed for breathing.
So normal voice is impossible.
Correct. Normal voice production is completely lost because there are no vocal cords for air to vibrate. This has huge implications for communication, obviously, but also for body image, social interaction. Even simple things like being able to smell normally or blow your nose are affected. The nursing care has to start way before surgery, preparing the patient psychologically, discussing communication alternatives involving speech therapy early, assessing their support systems. It's incredibly comprehensive.
That's a massive adjustment. Beyond the surgery itself, what's a common, maybe under-recognized challenge these patients face, sometimes even before treatment starts?
Malnutrition. It's a really significant risk and often present even before diagnosis or treatment begins.
Why is that?
Well, the tumor itself might cause pain or difficulty swallowing. Then treatment side effects compound it. Surgery causes swelling and pain. Radiation and chemotherapy often cause severe oral mucositis, painful sores and inflammation throughout the mouth and throat. Pace changes are common too. Eating just becomes incredibly difficult and painful.
So nutrition assessment is key. What can nurses do?
Thorough assessment is critical right from the start. For patients at high risk of nutritional problems, sometimes a prophylactic gastrostomy tube, GT, is placed before treatment even begins, allowing for enteral nutrition, tube feeding, to maintain their status. If they can eat orally, we encourage small, frequent meals of soft, bland, high-calorie, high-protein foods. Think about adding powdered milk to things, using nutritional supplements. Sauces and gravies can help moisten food. And after surgery, swallowing is almost always an issue initially. A swallow study might be done. We typically start with thickened liquids and pureed foods, with the patient sitting fully upright, high Fowler's position. Critically, avoid thin, watery fluids initially, as the aspiration risk is very high. Monitor closely for choking or respiratory distress during meals. Having suction available is important.
Thicken liquids, avoid thin fluids post-op.
Got it. Now, communication is obviously huge after a laryngectomy. What are the main options for voice restoration? Yeah, helping patients find a new way to communicate is incredibly important for their quality of life. There are basically three main methods. First, there's the electrolarynx. This is a handheld, battery-powered device placed against the neck or cheek. It creates vibrations that the patient can form into speech with their mouth. It allows for immediate speech after surgery and is relatively easy to learn, but the voice sounds, well, robotic or mechanical.
Okay, electrolarynx, immediate but mechanical. What else?
Second, and often considered the gold standard now, is tracheoesophageal puncture, or TTEP. This involves surgically creating a small fistula or channel between the trachea and the esophagus and placing a small one-way silicone valve prosthesis in it like the Bloomsinger valve. To speak, the patient inhales, covers their stoma with a finger, and forces air from the lungs through the prosthesis into the esophagus. This air vibrates the esophageal tissues, creating sound that they shape into words. It generally produces the most natural-sounding voice quality and has high patient satisfaction.
K-tip sounds promising. And the third option?
The third is esophageal speech. This is the oldest method, and it doesn't require any devices or further surgery. The person learns to swallow air into the top part of their esophagus and then expel it back up like a controlled burp, causing vibrations for speech. It takes a lot of practice and patience to learn, and the voice quality is often not as good as with TDEP. Fewer people use this method now.
Electrolarynx, TDEP, esophageal speech. Good overview. So bringing it back to the bedside nurse, especially right after surgery, what are those absolute must-do priorities?
Okay, post-op priorities. Number one, again, is airway management. Patients will have a tracheostomy tube initially, maybe just a scoma later. Keep them in a semi-Fowler's position, head elevated 30-45 degrees. This helps decrease edema and reduces tension on the suture lines. Frequent suctioning is crucial. Initially, secretions might be blood-tinged, then they'll likely become thicker. Adequate hydration and humidification, often via a track collar with humidified oxygen or air, are essential to keep secretions thin and prevent mucus plugs. Encourage deep breathing and coughing.
Airway, positioning, suctioning, humidification. What's next?
Pain management, definitely. Use appropriate analgesics. Remember, they might not be able to speak, so use nonverbal pain skills consistently. Then, monitoring for hemorrhage. The head and neck area is very vascular, so frequent vital signs are a must-watch: heart rate, blood pressure, SpO2. Look for signs of active bleeding or expanding hematomas under the skin flaps. Check hemoglobin levels too.
Vigilant monitoring for bleeding. What about wound care?
Right. Don't change the initial surgical dressings unless specifically ordered. If there are skin flaps used for reconstruction, they need hourly checks. Initially look at color, temperature, capillary refill, check for edema. Sometimes a Doppler is used to check for a pulse in the flap. Monitor drainage tubes like Hemovax or Jackson Pratt's hourly at first, then maybe every 4 hours. Note the amount and color of drainage should go from bloody to cerosanguineous, pinkish, to serous, clear yellow, and decrease over time. Ensure the drains are patent to prevent fluid buildup like hematomas or seromas under the flaps.
Hourly checks on flaps and drains initially.
No.
And if they have an NG tube placed during surgery?
If an NG tube was placed by the surgeon, do not manipulate it or reposition it unless you have a specific order. You could disrupt the internal suture lines. Enteral feedings via NG or GT usually start slowly once bowel sounds return.
Got it. Don't touch this surgeon-placed NG tube. Now, many patients also get radiation. What are the big side effects nurses need to manage?
Radiation to the head and neck causes some really tough side effects. Xerostomia, or dry mouth, is almost universal and often permanent. Management includes encouraging frequent sips of water, using saliva substitutes, sugarless gum, or candy to stimulate saliva. Sometimes a medication like pilocarpine is prescribed. Good oral hygiene and fluoride treatments are vital to prevent cavities. Oral mucositis is another major one: severe soreness, ulceration. Teach meticulous but gentle oral care. Soft toothbrush, flossing if possible, maybe using gauze pads. Recommend warm, bland rinses like salt and baking soda in water several times a day. Ice chips can sometimes help soothe. And critically, tell them to avoid commercial mouthwashes, especially those with alcohol, and avoid hot, spicy, or acidic foods that will further irritate the mucosa.
Good tips for mucositis. What about skin reactions and fatigue?
Yeah, skin in the radiation field can become red, irritated, almost like a sunburn. Patients should only use prescribed lotions, like aloe vera-based ones, and avoid applying them within 2 hours before treatment. Protect the skin from sun exposure. And fatigue is incredibly common and can be debilitating. Encourage gentle exercise like short daily walks, help them prioritize activities, schedule rest periods, and identify support systems.
Okay. And thinking longer term about life at home, what about stoma care and the psychosocial aspect?
Stoma care becomes a daily routine. Teach them to wash the area around the stoma daily with a moist cloth. They might need to use a nasal wash spray into the stoma a few times a day to keep secretions moist and prevent crusting. Dried secretions might need to be gently removed with tweezers. If they have a laryngectomy tube, the inner cannula needs daily cleaning. They should learn to cover the stoma when coughing or sneezing. Also cover it during activities like shaving or applying makeup. A special plastic collar can allow showering, but swimming is absolutely contraindicated because water could enter the lungs directly through the stoma. Using a bedside humidifier, especially at night, is often recommended.
No swimming. That's a huge safety point. And the psychosocial side.
It's immense. Depression, anxiety, altered body image, concerns about sexuality, these are very common. As nurses, we need to create a safe space for them to express feelings, convey acceptance, and offer resources like support groups. The American Cancer Society often has resources for laryngectomies. Sometimes a psychiatric referral is needed for severe depression. Encourage open communication between the patient and their partner about intimacy.
Okay. And for discharge planning, any final key points?
Definitely. A home health referral might be needed, especially if they're going home with a feeding tube. Provide clear written instructions, maybe with pictures, for stoma care, tube care, medications. Encourage self-care as much as possible to foster independence. Two really important safety items. They must get a medical alert bracelet or necklace indicating they are a neck breather. This is crucial for emergency responders. And because they often lose their sense of smell, they absolutely need working smoke detectors and carbon monoxide detectors in their home. Help them with dietary adjustments, maybe refer them to a dietitian. Encourage resuming activities and work when they feel able, though it might not be full-time initially. Really prepare them, honestly, for the overwhelming changes in the altered speech, changes in taste and smell, the permanent stoma. It's a huge adaptation.
Medic alert and smoke CO detectors, critical safety points. Wow. Okay, that was a lot, but so important. So let's try to synthesize this. What does all this mean for you, the nursing student listening? It means being able to recognize those subtle signs, like a deviated septum causing issues, or understanding the critical difference between managing an anterior versus a posterior nosebleed. And it really means grasping the profound impact and the very complex journey of a patient dealing with head and neck cancer. Every single piece of this puzzle we've discussed is vital if you want to provide truly holistic, truly patient-centered care. I think our main clinical takeaways today really circle around vigilance in your assessment, precision in your interventions, like knowing those drug alerts or post-op precautions, and deep compassion in patient education, especially when helping people adapt to huge lifestyle changes and new ways of communicating and living.
Absolutely. And what often strikes me is just the sheer breadth of nursing care involved here. You go from applying basic first aid for a nosebleed, which seems simple but needs to be done right, all the way to the incredibly intricate long-term care needed after a laryngectomy. The nurse really is that central coordinator, the educator, the advocate, and the emotional support system through it all. And maybe just a provocative thought to leave you with. Consider how advancements in technology are changing things. We have new surgical techniques, better radiation planning, even things like AI-powered speech devices are emerging. How will these continue to transform the nursing care we provide for patients with upper respiratory issues and head and neck cancers? What new skills might nurses need? What new roles or responsibilities might we take on as these innovations become more mainstream?
That is a fantastic thought. How will technology continue to shape our role? It really emphasizes how dynamic our profession is. We really hope this deep dive has given you some clarity and boosted your confidence as you continue on your nursing journey. Thank you so much for joining us on the deep dive.